So, good afternoon, everyone. So, I'm going to quickly touch upon keratoconus diagnosis and cross-linking protocols. I'm not going to actually get into the whole basics about keratoconus diagnosis, as I think it was already discussed earlier today morning. I'll just briefly touch upon the recent developments in your diagnosis protocols that you might be able to use. So, to introduce, as we know, keratoconus is a progressive ectatic corneal disorder characterized by thinning, protrusion, and irregular astigmatism. So, there are new technologies that one must consider to probably diagnose keratoconus a little earlier and help in management of this disease. One of these is the new epithelial thickness maps. Nowadays, in the newer topographers, this is something that is very prevalent. If you're using the MS39 or the RT view, you'll be able to see the epithelial thickness profile around the cone. Usually, what it looks like is on the in the apex of the cone, we can see epithelial thinning, and there'll be epithelial hypertrophy around the base of the cone. So this is an example of a patient who came to us with keratoconus. As you can see very clearly here, there is there is an inferior steepening in comparison to the superior aspect, and in the area of the cone, if you look at the epithelial maps on the right upper hand corner, there is a clear thinning of the epithelium, where the epithelial thickness is in the 40s and the surrounding epithelium is in the 50s. So usually this even shows up in the early stage of keratoconus as well. If I had just one investigation to look at before I deem a patient eligible for refractive surgery, I can very confidently say it will be epithelial thickness. So this is very sensitive, as it even picks up early stages of keratoconus very easily. And you can diagnose form first keratoconus, and you can defer corneal refractive surgery for these patients. The other thing is the Corvus biomechanics. So as you know, now Corvus is something that is now being looked at a little more. This is a device that, yeah, it's like an air puff tonometer where it deforms the cornea, and there's a Scheimpflug camera which is able to capture the rate of deformation and how it bounces back to its normal structural integrity. So this will help us to differentiate a true keratoconus from keratoconus like conditions. And what it uses is it uses something known as a tomographic and a biomechanical index, which is known as a TBI and CBI. So one is just CBI, which is the Corvus biomechanics, which it tells us how stiff the cornea is, and TBI is another index that it uses along with the findings in your pentacam, where it looks at the bad index and it combines both and uses an algorithm to tell you if the cornea you're looking at is keratoconic or not. So here, as you can see, the TBI is very high. It is close to it is close to 1. Anything that is more than 0.5 is supposed to be pathologic for keratoconus, and you're not supposed to touch that cornea for any refractive surgery. Another thing that is now coming up are tear film biomarkers. These are inflammatory markers that are usually elevated during keratoconus, such as MMP9, interleukin 6, and TNF alpha. All of this could provide a non-invasive early detection, but this is not really FDA approved, or it's not really common practice yet. If you have access to a high resolution OCT, this can also capture very high definition images. It can also help you locate stromal thinning. And it will also give you epithelial thickness maps to locate the apex of the cone and look for any epithelial thinning that could be occurring, indicative of keratoconus. The other things that you can use your biometers and look at the refractive stability. The parameters may include the Kmax, uncorrected distance vision acuity, and corrected distance visual acuity, and progressive thinning of the cornea that you can see in pachymetry. So use all of these new advancements to diagnose keratoconus a little earlier, and you can appropriately treat them by doing cross-linking. So as you know, cross-linking is a procedure that biomechanically strengthens the stiffness of the cornea, and it will also at least maintain or reduce further steepening as well. So in cross-linking, the triad, you need three things. You need oxygen, you need riboflavin, and you need UVA exposure. Generally, when we do this cross-linking, we need to remove the epithelium because riboflavin is a hydrophilic molecule, and hence it can't penetrate the epithelium. So we need to remove the central 7 millimeters of epithelium for the riboflavin to penetrate. Generally, we use 0.1% riboflavin. It's now available both as hypo or hyperosmolar forms, depending on whether you want to do epithelium off cross-linking or epithelium on cross-linking. So currently, these formulations are available depending upon what type of cross-linking you want to use. UVA exposure is usually done at 365 to 370 nanometers. And oxygen is also a very critical point in cross-linking, as O2 depletion is the rate limiting step in your collagen cross-linking. So what happens is the riboflavin reacts with UVA to produce free radicals, and these singlet oxygens react with the collagens, forming further crosslinks, hence stiffening the cornea. O2 is naturally present in the atmosphere, but if you want to enhance the rate of cross-linking, this can also be artificially supplemented. So generally, we don't want to cross-link corneas which are too thin because they might be toxic to the endothelium and cause decompensation. So in the general Dresden protocol that was originally described, minimum 400 microns of cross-linking is needed. So this is the original standard operating procedure for collagen cross-linking, in which the epithelium is removed, the cornea is soaked with riboflavin for 30 minutes, and every 3 to 5 minutes this riboflavin is replenished. Finally, you expose the cornea to a UV light of 395 nanometers for 30 minutes at 3 megawatts. So the total energy that should be used is 5.4 joules per centimeter square. So this is the mechanism of the cross-linking where the UVA acts with the riboflavin present in the cornea. This causes the production of free radicals and cross-linking of the collagen fibers. You can also verify that the cross-linking has been done by looking for a demarcation line. It will be visible in the slit lamp, or even better, the best way to visualize it is by looking at the ASOCT image. So generally, we do it in progressive ectasia, progressive corneal ectasia. And if you see in the 6 months follow-up, if you are seeing the ectasia is increasing by more than 1 diopter, or the manifest refraction is increasing by more than 1 diopter, or a decrease in pachymetry by 10%, all of these are signs that you must try to intervene and perform your C3R. So like I said, the Dresden protocol originally dictated that you must use an energy of 5.4 joules per centimeter square. But now in accelerated C3R, these new protocols, they do deliver the same amount of energy, but by reducing the amount of time that is there and increasing the exposure. So this is something known as the Bunsen-Roscoe law of reciprocity, whereas if you want, you can reduce the time but increase the power so that the total energy delivered will be the same. So you can do 30 megawatts per centimeter for 3 minutes, or 18 megawatts per centimeter for 5 minutes, or 9 megawatts per centimeter square for 10 minutes. Ultimately, whichever protocol you choose, you will be delivering the same amount of energy. But generally, the dictum is that if you're doing it for less than 10 minutes, it's probably not that efficient. So customized C3R is something that is based on a concept that the steepest point of the cornea is more weak than the peripheral cornea. So you can use concentric or sectoral delivery of UV light, where the UV delivery is enhanced to the area of the cone, and the area surrounding the cones gets a little lesser UV light because they don't need so much. So you can map this out in your topography and do selective epithelial debridement in these areas alone, and expose those areas of the cornea to the amount of energy that you would like to require. Now, for thin corneas, you can do something known as transepithelial cross-linking, where you maintain the epithelium and use a hyperosmolar riboflavin to penetrate. And this will also cause cross-linking to occur without the disadvantage of epi-off cross-linking that you might be having in the Dresden protocol of C3R. That can be done. This can also be done with iontophoresis, where we use a negatively charged riboflavin and we use a positive electrode placed in the vicinity of the patient to allow the riboflavin molecules to pass through the epithelium. You can also do an adaptive fluence, where if you have a thinner cornea, you don't have to use so much energy. The nomogram here is if the cornea is around 360 microns, you can reduce the amount of energy by 10%. Transepithelial C3R, like I said, it can be done in one of many ways. You can use iontophoresis, or you can use hyperosmolar riboflavin. So this is the technique that we use in our center, where we use a technique of epithelium on cross-linking. We've never been removing the epithelium for cross-linking from any of our patients. What we do is we use the flax cone for this method, center the cone over the cornea and use 0.1% riboflavin and fill it up to 3 mm. Following this, you can start bubbling the oxygen through the flax cone tube. And after you finish bubbling, place a sterile drape over it. This is done for 15 minutes. So after we bubble the riboflavin, every 3 minutes we keep replenishing it and do an accelerated form of cross-linking with UVA application of 40 megawatts per centimeter square. So this is done for 15 minutes at a time. So this is the video of the same here. As you can see, this is the flax cone. Filling it up with 0.1% riboflavin, and you supplement oxygen through the tube. And you can see here that the riboflavin starts to bubble out. So as it's bubbling out, we can place a sterile drape over this. So once you place a sterile drape, what you're doing here is you're increasing the pressure inside this chamber. So as this pressure increases, you will find that the riboflavin is able to penetrate through that intact epithelium. And every 3 minutes, what we do is we keep replenishing the riboflavin as it's getting depleted inside the chamber to ensure that this reaction is continuously occurring for 15 minutes at a time. And after we do this, we can go ahead and apply the UVA light at a power of 40 megawatts per centimeter square for a duration of 15 minutes. So we've been doing this consistently for the last 5 years, and we've seen that the results are very good. We're able to see a good demarcation line on the ASOCT, albeit yes, the demarcation line is more anterior than epi-off cross-linking. And in some cases, we've also seen flattening of the cornea. So when we've seen flattening, we know that for sure that yes, this protocol does work. You can also use extra procedures where after you've done PRK, LASIK or SMILE, you can have an added on C3R for borderline corneas, which you feel could be at risk for ectasia after a laser vision correction. In this, what we do is we use 0.25% riboflavin. We soak it in the stroma just for 90 seconds. In post-refractive, because you're directly entering the stroma, you don't have to soak it for too long. After 90 seconds of soakage, you can wash it out, and we apply 30 megawatts per centimeter square riboflavin UVA exposure for a total of 90 seconds. The energy delivered is 2.7 millijoules. So this is SMILE extra being performed. We do the SMILE procedure. This is the docking and the laser application. So both the cross-linking and the refractive procedure can be done in the same sitting. This is just a routine SMILE here. There's nothing different. We start with the anterior plane dissection and move on to the posterior plane dissection. So this is the anterior plane. And this is the posterior plane dissection. So once that is done, we just extract the lenticule. And then we can proceed with the cross-linking. Here what we do is, we inject the riboflavin directly into the stromal interface, allow it to soak for 90 seconds, and then we wash it out thoroughly. And then we can proceed with the UV application. So this we do in borderline corneas where we feel if you do a refractive surgery, there might be a small risk of ectasia. So we do it as an extra margin of safety. So my 10 commandments are, so yes, in addition to your corneal topography, if you have access to epithelial thickness maps, please do look at it. Never assess one eye in isolation. Do look at the fellow eye also. If the fellow eye has any indications of keratoconus, please relook it again. Use both topography and tomography, because topography alone only looks at the anterior curvature. You must look at posterior curvature also when you're looking at your corneas. So it is better to use tomography here. Biomechanics could be an advantage. So you can, if you have access to the Corvus or any other biomechanical devices, it can strengthen your diagnosis. Initiate C3R promptly in progressive cases. Here I take a little bit of a different stance. When I see keratoconus, I do tend to do C3R earlier, because we generally do epi on C3R, which has no downsides. In epi off C3R, because the risk of haze or scarring or uncontrolled flattening, you might want to think twice. But if you're doing epi on, if you see keratoconus, it doesn't hurt at all to do a C3R immediately. Accelerated C3R protocols are quite safe and effective, including epi on protocols. Epi on C3R may aid in better recovery. It has lesser scarring, lesser flattening effect, and generally those corneas are visually much better than an epi of C3R. So you can always cross-link, but look at pachymetry first. If the pachymetry is very less, do consider epi on C3R or use a hyperosmolar riboflavin. Combine refractive surgery with C3R in doubtful cases. If you have any doubt, do combine your refractive procedures along with the C3R for added on a safety margin. and customize the treatment to every cornea. You don't have to stick to only epi-off or only epi-on. Look at the parameters and choose the best technique of C3R for your patients that you think is going to work in your hands. Thank you for your attention.
Thank you, sir, for the excellent presentation. Sir, one question.
Yeah.
What is the minimum corneal thickness for epi-on technique?
No, epi-on, you really don't look at the minimum thickness because you are preserving the epithelium. So that's one of the advantages. See, the main advantage is that you don't have that scarring. The cornea doesn't flatten uncontrollably. Sometimes in the epi-off C3R corneas, you see even after 5 years, they continue to flatten. You don't see that with the epi-on. So that's the main reason why I prefer that.